Good afternoon, everyone. We are coming to you live from the core at the Lawn Cantata. Today, we are here with Dr. Nielsen. We are discussing scoliosis and technology. It's the latest and greatest technology on scoliosis and pediatrics. For the live stream audience, we do have an in-person audience here at the core with us. They will be asking questions. If any of you have any questions online, feel free to type them in. We will relay them to the doctor, and he can answer those as well. Otherwise, Dr. Nielsen.
All right, thanks for having me here. For those of you online, we have a sellout crowd here today. It's pretty great. Glad to have everybody here and talk about scoliosis. This, for me, is a really kind of nice topic. I like it. This is one of my favorite things to talk about, favorite things to take care of, and I think that it has a lot of things that people need to know about it. So we'll talk and then at the end answer questions and go from there. So as you can imagine, the spine has a lot of anatomy. There are very complex structures. Right in the middle of this picture, it shows the front, the back, and the side view of the spine. You can see that it's broken down into three different components: the cervical, thoracic, and lumbar vertebrae. Then there's the sacrum as well. And then there's, of course, what's not shown on here is all the things that come out of the spine and all the things that attach onto the spine. So it's a very complicated structure, very important structure. And as you can imagine, when it has all of these functions, it can be a little bit difficult to work around. And there can be a few things that go wrong. So here's just another representation of the spine. On the left-hand side, you see a regular radiograph. And for years, that's all we had to work with when we looked at the spine and when we took care of it. Now, of course, other technology has developed, and that's one thing that I'm going to talk about today is some of this new technology. The MRI picture on the right, that shows two different sequences that show different things. The MRI will show more of the three-dimensional anatomy, even though it's a two-dimensional picture, but you can start to get a better picture of where things are located, what structures are close to other structures, and what you have to be careful of. So let's jump right into scoliosis. This is, of course, a structure or a twisting of the spine that results in a three-dimensional problem. You can see the x-ray on the left and then the patient bending forward on the right. And that's sort of a radiographic and clinical representation of what's going on. Now, the one thing that I want you to know about scoliosis today is that it's not just a bend and it's not just a twist. It's a corkscrewing of the spine. One way that you can think about it is perhaps one half of the spine grows faster than the other half, and it just sort of twists as it goes up. And that's why on the x-ray you see this bend, but when you see a patient bend over like here and take a tangential x-ray, you can see that the ribs are pushed up there. And that's the rib bump that you have, that rotation of the spine. And everybody wonders what that rib bump, what that bump on your back is. I've actually, believe it or not, over the last 20 years, have had 3 people come to my office that have had thousands of dollars of workup for tumors because they thought they had some sort of tumor. Turns out it's just scoliosis. So it can throw people off a little bit. Now, scoliosis is a bend from the front. And like most things, there is an evil twin sister. And kyphosis happens to be the bend from the side. So when you have somebody bend over and they have this bump like this, that is called kyphosis. Now, I'll sort of refer to them similarly, but they're two separate processes. We just sort of treat them similarly. Now, I'd just like to kind of briefly educate you a little bit about the types of scoliosis. There are 3 types. The first is congenital. Now, congenital scoliosis is basically where you're born with abnormal vertebrae. So you have differences in how they're shaped or how they're stuck together. This type of scoliosis can be either exceedingly difficult or very easy to take care of. There's sort of no middle ground. It's just hard or easy. Fortunately, it's not very common. Neuromuscular is pretty common. Most of these patients have some sort of neuromuscular disease. such as spina bifida, cerebral palsy, any of the dystrophies, even spinal cord injuries like paralysis and those type of things can cause scoliosis. And this is to a large degree influenced by the spasticity or the pull of the muscles. Now, this represents the vast majority of cases of scoliosis. Idiopathic scoliosis is what we call it, and there can be three types of that, and that depends on what age you develop it at. If you have it under the age of 5, we call it infantile. If it's between 5 and 11, it's juvenile. And if it's above 12, then adolescent. And this represents 4 siblings that all have scoliosis. And I will point out that I have 4 daughters, and they all have scoliosis as well. So it does run in families and tends to be a little bit genetic in that way. So people like to know who, when, and why. It's a pretty common disorder. In fact, it's the most common disorder that people get, and believe it or not, 2% of the population has it. So very, very common. You probably know other people that have it, even though you may not know that. Now, it's something, we don't really know what causes it. There's something that is related to the hormone system that is part of this. There's a certain hormone called calmodulin, and if you take that hormone away from chickens, they all get scoliosis. Now, humans, fortunately, are a little bit more complex than chickens, and so that's not the full story, but nevertheless, it's something related. As a side note, I actually have a chicken with scoliosis, which I am pretty proud of. The other thing about it is that it is related to growth, and that's what this that's what this graph shows. Now, I'm specifically going to focus on young women because it's 10 times more common in girls than boys. And actually, for all the boys that have it out there, we don't treat it the same either. And I'll point out some of the differences as we go along. Now, what this graph shows is a graph of growth from the age of 6 up to about 20. And what it shows is that growth is pretty steady. And then there's a spike of growth, which we lovingly refer to as puberty. And then it sort of tapers down over time. Now, the red star represents the onset of menses. And that's a pretty important part when we start thinking about scoliosis, because peak growth happens typically before the onset of menses. And so if I see a patient that has not had their first period yet, then I am a little bit more worried that they are going to progress than somebody that had it a year or 2 ago, if that makes sense. Okay, so once you think you have it, how do you make the diagnosis? And it's actually pretty easy. These 3 pictures sort of represent what can be done. If you look at the young woman on the left, you see that her waist is asymmetric and there's an indentation on the right side of her chest. When she bends forward, there's that rib bump that we already talked about. This test where you bend forward and look at the back, that's called the Allen test, but it's pretty easy just to look at somebody's back and have them do that, and you can tell if they have scoliosis. If you want to quantify it, you have to get an x-ray, but this little device here called a scoliometer can be a brief, kind of quick and dirty way of looking at it. Just about a 7-degree curve on a scoliometer typically represents about a 20-degree curve on an x-ray, just for reference. Okay, so now that you or your mom or your primary doctor or somebody found it, what do you expect? I think that these are the most common questions that people have. Now, there's all kinds of questions, but is there going to be pain? Believe it or not, somebody did a study once where they showed that people had no pain, and then after the diagnosis of scoliosis, all of a sudden, temporarily, they had pain for a few months. And so there is, there's a little bit of a component of worry about it that goes into it. Is it going to progress? Will I have some horrible deformity? Is there going to be organ damage? Do I need surgery or bracing? All of these different questions need to be asked. So to answer those, let's talk about some of the basic treatment. Now, I kind of break scoliosis down into 3 categories. The small curve, which is 0 to 20, the medium curve from 20 to 45, and then the big curves, which are over 50. Typically, if it's under 20, we don't really do anything, and that's pretty much true for all age groups. If it's over 50, we start talking about surgery to fix it, and there's a very important reason for that I'll talk about in a minute. Now, it's the group that is in the middle, the gray group, the 20 to 45 degree group, that the treatment is a little bit important. Now, adjuncts to medical treatment, including physical therapy, chiropractic, yoga. I will point out I'm at the core. This is a great place to come and get your exercise. Anything that will help keep your core strong and your curve flexible is going to help this curve. Now, chiropractic and those things won't take the curve away, but they will certainly help with pain and help with the stiffness and those type of things. So I'm going to get back to the brace treatment. So, does bracing actually work? And I see that I have a lovely young woman here that is wearing a brace. I don't know. Why don't you come up here for a minute? But bring your chair. We're going to have audience participation for a minute. Come right up here. You got to put it on this thing, and I'm going to make sure you're tall enough. So stand on the chair. Don't fall off. I'll be in trouble. Okay, so what's your name?
Jillian?
Jillian. So Jillian clearly has a brace on. How does it, what do you think about that brace?
Well, it has to be like, when you first get it, you have to get used to it because it's going to feel weird. So
It's true.
every time I get a new one, I'm like, why does this feel so weird? Because I got to get used to it. And you have to wear it 20 hours a day. So that means you have to sleep in it.
Yeah, it's kind of hard, isn't it?
Yeah.
It's hot in Arizona, isn't it?
Mm-hmm.
Yeah. I can tell you're wearing it good, though.
Mm-hmm.
Okay, thanks. Okay, we have a perfect example of a brace user. She looks to be right about the right age, and it looks like she's compliant, so perfect. All right, the real question is does bracing really work? And there's some things you need to understand about bracing. This shows some of the different types of brace. The brace on the left was one of the original braces. It was called the Milwaukee brace, straight out of medieval torture. Back when I was in my training, a few people were still in these. They are absolutely impossible to wear. The main type of brace is the kind that Jillian has, which is that TLSO, which is kind of the clamshell. There is a nighttime bending brace called a Charleston brace that some people can use, but it has to be used for a specific type of curve. And that one is nice because it's only used at nighttime. The spine core brace, and there are a few other types of braces that really work on putting pressure points on the spine, can be useful, but I can tell you it is almost impossible to go to the bathroom with one of these braces on. So that's something to consider. Now, the thing to know about bracing is that it only works for a very specific subgroup of patients. We used to brace a lot of people, and when I was in high school, I remember one of my friends, he was a boy, and he wore a brace for pretty much all of high school. Well, we've learned a lot of things about bracing since then. First of all, we've learned that braces don't really work in boys. So it's a very rare boy that we use a brace in. Number two, braces only work in a very selective group of young women. It's typically young women that have curves between 20 and 40 and have not had their first period yet. So once someone has had their first menses, they're really no longer a candidate for a brace. It just doesn't work. Now, there are some other important things about using a brace. When you have it on for 20 hours a day, you're going to get weak in the core. So you have to make a concerted effort to get exercise if you're going to wear a brace, because otherwise the curve will actually get worse. Okay, so once you have started treatment or embarked on this process of being treated, there are some things you can do to have a good outcome. Typically, there are 4 things you have to pay attention to. Most of my patients need work with 3 and not 4. The first is that I'll just mention is no smoking. Smoking is highly correlated with back pain. Gets worse if you have scoliosis. It's just a bad deal. The 3 that are important: core strength, flexibility, and posture. If you can concentrate on those 3 things, you pretty much guarantee that you're going to have the best outcome possible. So you have to find a way to keep your core strong, stay flexible, and then just stand up straight. And that's hard for teenagers. Okay, so let's shift gears a little bit here. I want to get into some of the technology that has changed scoliosis a little bit. So let's talk about what happens if you have to have surgery. Is it the end of the world? Some people think it is. It's not fun to have surgery. I had surgery a few years ago. It was not fun for me, and I know what I'm doing. So like anything, if you do it for the right reasons and you do it when you need to and with the proper people doing it, there are some pros that will definitely help you out. There are some cons too, but this is a young woman that had surgery. You can see her curvature before, and almost immediately post-operative, she has just so much improvement in how her back looks. So if you do have to have surgery, and typically I will point out that there are some general rules for having surgery, and probably the most significant is that the curve is over 50. So there are a few things that go into that decision that you can talk about with your doctor, but sort of the baseline is a curve around 50. And once it's over 50, then you start that discussion. Now, as you can imagine, surgery to fix this is pretty technically demanding and can be challenging. There's kind of crazy anatomy in your back, and scoliosis just makes it worse. So you have to find a way to be able to fix it, but fix it safely and do it without causing the patient any problems, and yet at the same time correct the problem. So typically to fix this, we use something called pedicle screws. And these are screws that are put in the spine, and then we hook some rods up to them and use a combination of rotation techniques and straighten the spine out. Now, a couple things I want to point out is that most of the anatomy around the spine that we're working around is very complicated. Now, the picture on the left is a cartoon that shows a screw that's kind of superimposed in the vertebral body, and that is where you want to put the screw. The problem is you're doing it blind. You can only see the top of the bone, and you can't see anything underneath that. So you have to know your anatomy very well, which is super important. It also helps to do well in organic chemistry because you start to rotate those molecules around in your head and you get used to seeing things this way. So you can see the spinal cord and how close that is to the screws. And on the other side are the vessels. So you have to be careful not only of the nerves, but also the blood vessels. To make it worse, on the right, you see a cross-section of a CT scan, and you can see that everything is twisted and bent and rotated a little bit. And that makes it even a little bit more difficult to know where to put those things. I can't point because I don't have a pointer, but just to the side of the spine there, you can see the aorta, and that big round thing in the middle is the heart. So you got to be pretty careful in how you're doing this. Now, I don't want to freak you out, especially you, Jillian. I don't know your back, but there can be problems when you do surgery. And now these are none of my patients, thank you. I want to point that out. But I got these pictures off the internet. But screws can be put in the wrong spot if you're not careful, and you have to work really hard to make sure that it's done right. I will point out that as a pediatric orthopedic surgeon, I went to 27th grade. So we spent a lot of time learning how to do this, and so it's important that it's done right. You can see that in some of these, it looks like the screw goes right through the canal, which it does, and I can tell you right now that's not a good outcome. So we have to find ways to make this better. And traditionally, screws can be put in the wrong spot. So what do you do to make that more accurate? Well, what I've started to do and have adopted in my practice and is becoming more popular with other surgeons as well is this patient-directed technology. So we use a CT scan and the patient's own anatomy to make this a lot safer. So basically what I will do is I'll get a CT scan of the spine, which is represented on the left there. And I send that off to Switzerland, and they make a cartoon model of that, which is in the middle, that green one. And then what I can do is I can take that computer image and I can put the hardware exactly where I want it. And I can pick the size and exactly how I want it positioned all before surgery, so there's no guesswork with that. And then we make some guides as represented on the right and use those in surgery, which I'll show you later. Use that to help put the hardware in. So this is what I see on my computer when I'm planning for surgery. I'll have this spine and the models, and I can click on those screws and move them exactly where I want and find exactly the right size and position. And there are some advantages about that I'll talk about in a minute. But if you look at the middle of the picture and you see the little blue screws right going down those holes, those are those little tubes you want the screw to enter. That's the pedicle. And you want the screw to fit properly, but not be too big or too small. If it's too small, it'll pull out. If it's too big, it'll cut through and get close to the nerves. So you have to make sure that's proper. And this is one way of knowing that size a little bit better than we could do just by guessing. So patient match technology, the CT type technology, improves the accuracy of the pedicle screw placement, and not only allows you to be more accurate in your screw placement, but also allows you to put screws in where you normally otherwise wouldn't be able to. When you get to the apex of the curve, it can be very difficult to get those screws in. The pedicles are very narrow and tight. The angles are funny. I can tell you that many times as I fix scoliosis, I'm actually putting a screw in that's supposed to go top to bottom, and my screwdriver is parallel to the floor because there's so much rotation in that spine. And this really helps get that in the right position. I mentioned that you match the screw size more appropriately to the bone, which allows you to get stronger fixation. And with the more screws that are placed and better, stronger screws, you can more perfectly fix the deformity, fix the rotation, give the patient a better result more safely, but also, interestingly, you don't have to fuse as many levels. So it used to be that we would go high and low, and now we can do a more focused fixation because we have better fixation. Other advantages, it's just safer. We know exactly where we're putting it. We have, I've been doing this type of technology for about 6 years now, and I can think of only 2 screws that I've not been able to get in this whole time. And before, I probably didn't put in 30% of screws because I wanted to be safe. It's taken an hour off my OR time. OR time is directly correlated with complications, more blood loss, more infection. And if you can get in and do it safely and get done and get the patient off the table, you definitely lower risks of infection and blood loss. In addition, we don't have to have any radiation in the OR anymore. Before putting in pedicle screws, we had an X-ray machine, and we would take 6 or 7 pictures at each level to be able to get the screw in. Now I don't even use the X-ray machine in the OR at all. And not only is that better for the patient, but myself, the anesthesiologist, the neuromonitoring tech, my assistant, the scrub tech, the scrub nurse, nobody's getting any radiation. So we'll show you some pictures here that represent surgery. And I'll just kind of run you through a quick little bit of the technique. First of all, we expose the patient. Now, if you look at this patient here, the head is on the left by the writing, and the feet are down at the other end. We basically, this little white guide that you see there, that is the guide that we make from the CT scan, and it literally fits right on the vertebrae. And then we work right through that guide to put the hardware in. So on the left, you can see I've got my hands in there, and I'm holding the guide, and I'm holding it right on the vertebrae, and it fits perfectly. Sorry, Jillian. It fits perfectly on there, and then I put a little wire right through it, and it goes right into the body, right through that tube of bone into the body. Once you get that wire on there, you can take a little drill and just open the cortex and then tap the hole. And once you get that done, you can feel in there and make sure that you're in the right place. Thereafter, you put the screw in and go to the next level. It's efficient, it's safe, and there's no guesswork. Now, what this demonstrates is how you correct the rotational abnormality of the spine. So we put these towers on and connect it to the screws, and it becomes a rigid construct. And if you look at it kind of across the patient, you can see that these tubes are about 1 foot tall, and they're rigidly connected to the spine. We then hook them up together and put these handles on. And you can see in this picture, the whole construct is put together. It's got the handles, everything's locked together in different configurations. And then in the picture on the right, I'm correcting the rotation and correcting the rib hump, and my assistant is tightening the screws and locking it all down. So you can see that when you're doing this type of technique, you've got to have good fixation, and you can't have screws that are marginal or in the wrong spot because you're going to cause problems. But with this, you can get better correction and correct the deformity so that the patient doesn't have to worry about all that. So here's just an example. Here's a young woman with scoliosis. This is the front view and the side view. You can see that it's a pretty big curve. And after we fixed her, you can see the screws, and she's basically perfectly straight. I'm going to go back again. You can see over on the right side, the ribs sticking out in the back, and they are no longer. So we've corrected the deformity in both planes, and she looks great and did fine. So once again, just to summarize, scoliosis is an interesting problem that we have really come a long way in understanding. When I got out of my training 20 years ago, we were just starting to use pedicle screws for the correction of scoliosis. A lot of people were still using hooks and kind of the old ways of doing things. Things have progressed, and it seems like every 5 years there's a huge advancement that really significantly changes things. In my opinion, scoliosis surgery, because of technology, has become safer. It's become more appropriate. The long-term outcomes are better. The correction is better. The patients are safer. And I think that this has been a real improvement in how we take care of patients. So if you have scoliosis or you know somebody that has it, there are lots of things to consider during treatment. Definitely work with your doctor. Start paying attention to your core strength. Start paying attention to your posture and flexibility. If you do end up needing surgery, do it for the right reasons. And if you do it and it's done well, you shouldn't have problems throughout your whole life. I think it usually works out pretty well. If you have detailed questions about this, there's 2 really good resources. Most of the resources on the internet are not worth much at all, and I would be careful about anybody telling you about their outcome. It's sketchy to begin with, but if you go to srs.org or aaos.org, that's where you can get really reliable information on how to take care of this and what to expect with it. So that is it for my presentation. What questions?
I was just going to ask really quickly, is there any thought to get an EOS machine here in Tucson?
Well, you have, if you have a huge enough amount of money, no, not that I'm aware of. There are some advantages and disadvantages to an EOS machine. The question was about a specific type of X-ray machine that takes an almost 3-dimensional X-ray picture. There are some advantages to it. With this patient match technology, it's not as important. So there is not one in Tucson. I believe they have one up in Phoenix.
That's where
Yep. But it depends on how you're taking care of this. If you're used to using that type of machine, it can be useful. If you are used to using other methods, it can be just as useful. Yeah.
Could you speak a bit about adolescent boys?
Yeah, sure. The question was, is there a difference between adolescent boys and girls? Yes, there are a couple of notable differences. First of all, with boys, once again, scoliosis is 10 times more common in girls than boys. And when boys get it, typically there's less chance of progressing on to need surgery. The studies have shown that most boys get up into about the 30-degree range and then don't really get worse after that. Now, some do, of course, but they tend to stop progressing somewhere in the 30s for unknown reasons. Once again, we don't really treat boys with braces unless they're really, really young. Sometimes for infantile and juvenile scoliosis, we will use some bracing and sometimes even some casting if they're really little. But after that, in the adolescent period, it just is not effective. Now, once you get beyond 50 degrees, everything sort of equals out with young women. So the surgery is the same, the outcomes are the same, all that is the same. It's basically the treatment of the adolescents before it gets to 50 degrees that is a little bit different. Now, one thing that I would like to mention is back in the day in Iowa, they did a study where they took a lot of patients and they didn't treat them at all, and they followed them for their whole life. And they looked at their outcomes and what to expect over time. And they found that people that have scoliosis that never had any treatment had a couple of things that were detrimental, but overall they did fine. First of all, they had more days of work missed because of back pain. Once curves get big, they tend to be painful. And so these people that were untreated, they did fine in society. They held normal jobs, but they missed more days of work because of pain. The second thing that they found was that they had a lower body image. They didn't like the way they looked. They had big curves that they didn't like. And so those two things in consideration have sort of prompted some of the treatment of scoliosis. But I would just like to point out that if you decide not to have surgery, you're going to be okay. But you'll have pain, you'll have deformity, and there are some things you'll have to put up with.
I have two other questions, if it's okay.
Okay.
I wondered about, in your surgeries, is there a benefit to having surgery earlier as a younger body versus if someone waited until they were older?
Great question. So the question was if there is an advantage to having surgery earlier or later. The answer to that is really two-part. First, you need to be relatively mature before you do the surgery. If you are too immature, even if you fuse it, it can continue to progress. There's something in the pelvis called the triradiate cartilage, and we typically don't like to operate on that until that has closed, or operate on the spine until that has closed. Now, there are some exceptions to that, of course. The other thing to consider is that the older you get, the stiffer you get, and the bigger the curve, the less you can correct it and the more chance for complications. So if you want to wait because you feel like you're too young and your curve gets 85 degrees and you get a little bit older and it's a stiff curve, at that point you just can't fix it that well. You can't get as good a correction. You have to fuse more levels. There are some other implications with healing, but more importantly, the complication rate goes up.
Last question, I promise. Is your technology common among surgeons, or are you the only one doing it?
Great question. The question was, is this technology common? Over the last 5 years, it has become much more common. I was with this company that I use, I was the first one to use it in North America, and it was about 5 years ago. There are a couple other companies that have popped up that do similar things. And when you go to the national meetings, a lot of people are talking about them. And I think that for severe curves with a lot of deformity, this type of technology is becoming much more common. And I think that it's becoming really mainstream. And I think that it's going to become even more popular in the future. Cost has been somewhat of an issue, but that has gone down. There was another segment of correction with computer or like robot type technology, but it's very expensive. It actually makes the surgery longer for the most part and really doesn't provide any accuracy benefits, at least in my hands. So, yeah.
We have about 5 questions
Okay.
on our live stream. So they want to know if pregnancy Does pregnancy having or slash having more children increase risk of worsening of the curvature?
Great question. So the question was about pregnancy and scoliosis. I'm going to answer that two parts. First of all, if you have scoliosis surgery, it doesn't have any effect on having children. You can still get pregnant. You can still have an epidural as long as you didn't get fused down too low. And so having your spine fixed shouldn't have any effect on childbirth. Now, once you have scoliosis and you have not had it treated, the question is whether having children is going to make that worse. Now, the act of having a child will not make your spine worse, but there are two things that will. First of all, if you become osteopenic or osteoporotic and lose calcium and your spine and your bones get a little bit softer, which can happen with pregnancy and which can happen with age, your spine is going to progress. And in fact, as if you have scoliosis and as you get older and develop osteoporosis, it definitely progresses. There's no question. The other thing is pregnancy wreaks havoc on your core. I mean, you've had this parasite that has expanded your belly hugely and just stretched everything out. And if you don't take time after you're pregnant and fix your core, yes, your curve could progress.
How common is it for a person with scoliosis to have a child with scoliosis?
The question is, how common is it for a person with scoliosis to have a child with scoliosis? I don't have numbers for you, but I can tell you that it is genetic and it does run in families. And if you have scoliosis, your children are definitely more at risk to have scoliosis. So there is a direct correlation.
Is there a sign that would signify a person older, like in the 30s, that would need an X-ray to make sure they don't have worsening curvature?
The question is whether someone in their 30s or older, is there a test that you can do to see if they have scoliosis or to see if it gets worse? The answer is yes. It's called the Allen test. It's very easy. You basically just have the person bend over and stand behind them, and if you see the rib bump, you know that they have scoliosis. You can monitor that if you just take a little picture and then compare it every year, around their birthday or whatever. But that little test where you bend forward is actually pretty accurate as far as looking at the progression.
And for a person that doesn't have a lot of pain, how would they know if they've gone from a 38-degree curve to a 50? And would it be obvious with the Allen test?
Great. Okay, so the question is, when a curve progresses, will you notice it pain-wise? In other words, do you have pain when your curve progresses? And the answer to that is somewhat mixed. Most people that have a slow progression don't have pain. And so if you start out with a 20-degree curve and over the next 3 years go up to 50, you're probably not going to know it when it comes to pain. Now, if you have a rapidly progressive curve and in 6 months go from 30 to 50, a lot of those people do show up with more pain in their back. So it's sort of the rapid progression that can lead you to think that it's going to hurt a little bit more. So if you have scoliosis and your back has been hurting more, there is a chance that it's progressed and it's probably at least worth checking. Okay.
So you mentioned braces work best for curves up to 40 and before onset of menses. At that point, is the cartilage typically developed to a point where permanent fixation is possible, or is there generally a gap in that process?
Okay, I think I know what the question is, and I'll answer it. So the question really is, braces are more effective with curves between 20 and 40 degrees. And is there at some point where the cartilage turns to bone and it does not, and that affects the effectiveness of the brace? And I think that's a pretty accurate statement. I think that bones when you're young and growing are somewhat plastic and easily manipulatable. And as you get older, they become stiffer and more fixed in their position. So A brace takes advantage of pushing on your ribs, which then push on your spine. And if you're flexible enough, you can get a little bit of correction. But the stiffer you get, the less chance of correction you're going to get. So as your curve gets bigger, over 40, it becomes stiffer and you just can't get the correction. And as you become older and your bones become more developed, it just doesn't correct anymore. I think that might have answered the question.
Now, for the Allen test, since most kids get that during the physical, how accurate is it? Can we miss scoliosis or diagnosis?
Okay, great question. The question is the Allen test, where you bend forward and look at the back, how accurate is that, and how easy is it to miss the diagnosis with that test? It's usually pretty reliable, but not everybody has equal amounts of rotation and bend. So there are some people that have a lot of bend and not much twist. And there are some people that have a lot of twist and not much bend. So in my own practice, every month I see somebody where I see them bend over and they look perfect. And I get an x-ray and there's a 40-degree curve. And I'm all, what the heck? And then similarly, they'll bend over and there's a huge rib bump. You get an x-ray and it's basically straight. So you have to use it with a little bit of caution because it's not exactly predictable of both the twist and the bend.
Somebody just wanted to know if your daughter's cases are similar or are they completely different?
They're all pretty similar, actually. Yeah, they all have less than a 30-degree curve and they look about the same.
That was all.
Oh, okay. All right. Well, I guess that's it then. Thank you very much. Oh, one more?
From a school nurse perspective, what would you share with us? What we could do to help the patients who have the surgeries?
Oh, okay. Great question. The question is, as school nurse, what can you do to help the patients that have had the surgery? So the nice thing about this surgery, well, one nice thing about this surgery is that when you leave the hospital, you don't have to have a brace. You don't have to have any special devices or anything like that. You're basically walking, you can bend and twist and all those things, but you have to do it pretty carefully. My own patients, I let them walk, swim, and ride a stationary bike from the start, but I don't let them play sports for 6 months. So if they're going to have PE, they can walk laps, but that's about it. If they're in weight class, they can ride a stationary bike or those type of things. Immediately, the other part to that is it's a big surgery. Most kids are about ready to go back to school after 3 weeks. So they stay in the hospital about 4 or 5 days. Then they're ready to go back to school at about 3 weeks. At that point, they need to really focus on having a lighter backpack than average and then put it on both shoulders. Don't just put it on one. They might need a little bit more time between classes. If they go to Tucson High, they will definitely need more time between classes because there are so many stairs. And then often it's helpful if they are able to stand up and down in class frequently. So if they can stand up every 15 minutes and stretch a little bit, it just makes them more comfortable. So. Yeah, that's just for comfort. It's not really necessary, but if it helps, it helps. Yeah. Okay. All right. Thanks, everybody.